We can go live, I think, and
So
maybe
we can go live, na?
Yeah, we can go live. And
Yeah,
Yeah.
let's go
So
live.
Kundan,
Just a minute. Yes.
Kundan,
Kunal, let me know
Kundan
once
just
I have to start here.
hi Deepak.
We are live now.
Hello.
Good evening, doctors.
Good
On
evening.
behalf of Zydus Healthcare, I extend a very warm welcome to each one of you to this webinar on sudden sensory neural hearing loss. Very happy to share that more than 2,000 leading ENT practitioners from across the country have logged in for this session. And not only this session is being broadcast to more than 25 medical colleges also. My name is Nitish Srivastava, and I work as a Senior VP with Zydus Healthcare Limited. And we are delighted to have you join us for this important and timely discussion. Sudden sensory neurohearing loss, as we all know, is a medical condition that can significantly impact a patient's quality of life. The sudden onset of hearing loss can be very distressing and require prompt diagnosis and management. Recognizing the challenges this condition poses, Zydus is committed to support ENT practitioner with latest information and insights to improve the patient's outcome. Today, we have the privilege of hearing the experiences and deliberation over this subject from some of the well-renowned experts and eminent otolaryngologists of our country. With the loads of experience, they will share their invaluable insight. Of course, my colleague, Dr. Pranali, will introduce to our elite group of the faculty to all of you. But I'll take this opportunity to thank Dr. Deepak Haldipur and my good friend, Dr. Daipavan, for conceptualizing this session and giving it a shape to make it so meaningful. Presence of Dr. V. Srinivas, Dr. Samir Bhargav, and Dr. Ravi Meher is definitely going to bring forth a lot of pearls of wisdom in this subject matter. We believe that this subject will provide you with practical knowledge and actionable strategies that you can implement in your daily practice. We encourage all of you to actively participate in this webinar by asking questions and sharing your experiences. We have allocated time for question and answer session also at the end of the presentation, where you can directly interact with our esteemed speakers. Once again, thank you so much for joining us. We are honored to have you all here. And now I would like to hand over the session to Dr. Pranali to take it forward. Thank you.
Thank you, Nitish sir. I'll now take a brief moment to introduce all the esteemed speakers with us today. Is my screen visible to everyone?
yes.
Okay.
Yeah, good.
So good evening, everyone, and welcome to today's medical session on timeless therapy, revisiting the vascular approach in sudden sensory neural hearing loss. We are privileged to have an exceptional panel of ENT experts with us today, each bringing a wealth of experience and expertise to this discussion. Let me introduce them to you. First, we have Dr. Deepak Haldipur, a senior consultant in otolaryngology from Bengaluru. Renowned for his expertise in endoscopic and microscopic ear surgeries, Dr. Haldipur is a key figure in the Indian ENT community and an active member of prestigious societies like the Indian Society of Otology. Joining him is Dr. V. Srinivas, professor and head of ENT at BGS Global Institute of Medical Sciences. With over 24 years of experience and international exposure, Dr. Srinivas specializes in microscopic and endoscopic ear surgeries and has published extensively on ENT disorders. Next, we have Dr. Dvaipayan Mukherjee, Professor and Head of ENT at KPC Medical College, Kolkata. A leader in the Association of Otolaryngologists of India, Dr. Mukherjee has organized major conferences like ICON 2017 and ISOCON 2019 and is a sought-after faculty member at national and international events. We are also joined by Dr. Samir Bhargava, a professor and ENT consultant from Mumbai, a gold medalist in ENT and former national president of the Association of Otolaryngologists of India. Dr. Bhargava has conducted over 75 surgical workshops and co-authored a widely read ENT textbook called A Short Textbook of ENT Diseases. Rounding out our panel is Dr. Ravi Meher, Director Professor at Maulana Azad Medical College, New Delhi, a globally recognized expert in skull base and endoscopic sinus surgeries. Dr. Meher is a fellow of multiple international medical academics like Royal College of Surgeons, Glasgow, and the American College of Surgeons, and a respected mentor in the field of ENT. Together, this distinguished panel brings a wealth of knowledge and experience to today's discussion. Let's give them a warm welcome. Now, to set the stage for today's discussion, I'd like to invite Dr. Deepak Haldipur to provide an overview of the webinar's context and the importance of revisiting the vascular approach in managing SNHL. Dr. Haldipur, over to you.
I think Dr. Haldipur sir has a connection issue. I think he's repeatedly getting disconnected. So in between he's going to join, then we can connect with him. Otherwise, you can start over with Dr. V. Srinivas directly.
Okay, sir.
Yeah, I think
Then
he's there now. Dr. Deepak, are you there, sir?
Yeah, I'm here.
Yes, sir, please.
Yes. My internet is weak also. I'm in a train. Gives me immense pleasure to introduce everybody and have this panel. And, Dr. V. Srinivas and me did our post-graduation together. Samir is a great friend and a great academician. And Dvaipayan and Ravi Meher, again, we are all on the same length when it comes to propagating ENT and its concepts. In fact, the sudden SS and SNHL was a concept first I heard from my teacher, Professor Madevaya. And today we all agree that the number of cases have tremendously increased. Maybe because of lifestyle, the COVID virus infection, we don't know whether it's due to COVID vaccination, many other factors, diabetes, stress, etc. So I personally feel that this is a topic of the future because we're going to see more and more cases on this. It gives me pleasure.
Maybe Deepak is traveling, so he's finding it network difficult. Hello?
I think. Yes, sir, we can start with your presentation, I think.
Yeah.
And moderate this thing.
For introducing and giving an overview of what is sudden sensorineural and where we stand in that management of SSHNL. So this is me and this is my college in Bengaluru, and let us start revisiting the vascular approach in vascular treatment approach in sudden sensorineural, which was once in our basket, but nowadays it is almost forgotten, but still we have to revisit and think about the vascular aspect, the vascular etiologies and treating the vascular etiologies of the thing. So let us go through this quickly. Before that, I'd like to thank the Sidus group for giving me this opportunity to speak on this role of vasodilators in sudden sensorineural hearing loss. And I say good evening to everybody who have joined us for this session. Thank you. As we all know, that the etiology of sudden sensorineural hearing loss are various. And of course, so we have all these infection, the viral infection, autoimmunity, ear disorders, cancers, mainly the inner ear tumors, traumatic endocrine disorders, and drugs adverse effects. And vascular component is also there. So first thing is the viral infections of 30%, and otology 5%. Vascular hemorrhagic hematological causes include about only 3% of the thing. But even then, revisiting and knowing about this vascular problems and how to gain something plus points in treating this sensorineural hearing loss. So the suggested treatment algorithm is just like this, where idiopathic sudden sensory hearing loss is graded into 1, 2, 3, 4, according to the amount of loss of sudden loss of hearing, according to the severity of hearing loss. And grade 1, 2, of course, we know the main rampant here is steroids. Either it can be oral steroids or it can be intratympanic steroids or parental steroids, which is usually start with them. But we should not forget about the vasodilators also, which also have a main role in treating this in grade 3 and 4. The more the grade, you better add the vasodilators. So that here we see in this, it has been given as prostaglandin E1. So that is also a vasodilator, which is used in grade 3 and 4. So we will, and of course, steroids and in vascular dilators are used much frequently in treating this etiology. So let us see what is the arterial anatomy, the blood supply of the inner ear or the cochlea itself. So all of you know that, everybody knows that ICA is the one which gives a branch of labyrinthine artery, which is an end artery. It's an end artery, so that there is no collaterals, there is no another supply from anywhere to the cochlea. It is the only end artery, and we know that it divides into anterior vestibular artery, and then gives a common cochlear artery, and then that divides into vestibulocochlear artery and main cochlear artery. So type 1 and type 2 has been described by this person called as Nadia, and the type 1 is where the MCA or the main cochlear artery takes part in that, giving supply to all the whole, that is the basal turn, middle turn, the apical turn. Type 2 is where the VCA or the vestibulocochlear artery takes up in the major role, but not the middle, not the main cochlear artery. So these two types. So these are all end arteries and almost small to medium-sized arteries, which can be affected in all kind of vascular problems. Generally, what we see in all the middle-size, medium-sized vessels. Then, why the vasodilators in sudden sensorineural hearing loss? Why? It has been taken up one of the things. So the thing is, there is a vascular theory for this, states that either infarction of cochlea or hemorrhage into the cochlea is one of the major cause for sudden sensorineural hearing loss. So on this theory based, so we can call this as almost cochlear stroke. Cochlear stroke, and all of us know that this is an audiological emergency. To be treated energetically like any other emergency, the audiological emergency that be treated energetically with the basket of whatever treatment we have for this. One of that is vasodilators. It is almost similar to the myocardial infarction, cerebrovascular stroke, and peripheral arterial disease. So it is similar to that, where cochlea suffers suddenly the loss of blood supply and it goes for infarction. So similar type of thing we see here also. So it can be either embolism, thrombosis, infarction, or hemorrhage. And usually the people with diabetes, hypertension, metabolic syndrome, or on anticoagulants will have hemorrhages, and thrombosis factor plays a very big role in them. And nowadays, of course, all of us are experiencing this new one, COVID and post-COVID hypercoagulability status, which is also affecting our region of cochlear artery and then causing this problem. All of us must be experiencing now about this COVID and post-COVID. We are seeing a lot of people coming with tinnitus, unrelented tinnitus, and also even your suddenly sensorineural hearing loss. The fact that most cases of idiopathic SSHL are of very rapid onset lends support to the hypothesis that this has a vascular cause. Anything, sudden onset. The sudden onset is the one which gives us a thought that this can be a vascular affection of the concerned region. So that's why the vascular etiology is also a strong etiology which is blamed for the idiopathic sensorineural hearing loss, sudden sensorineural hearing loss. So that's why we have vasodilators. These are the reasons why we have vasodilators as one of the section where we can use them. Some studies regarding this. A review focused on the contribution of vascular pathology is recently done by two Japanese people presented in Aureus Nasus Clarix on 2024 idiopathic sudden sensorineural hearing loss, which states that the final conclusion is that breakthroughs in the unequivocal diagnosis and treatment of this condition due to vascular impairment are crucial to improve quality of life. So they have stressed on the vascular impairment, and treatment of the vascular component also should be added, or it can be used as a single therapy also. But still now there is currently no evidence-based treatment for this one. But we know that all we have is different, all those drugs what we have, we can use for the sensorineural hearing loss. This study from the Cochrane Library, vasodilators and vasoactive substances for ISSHL, okay, taken from Cochrane database and systematic reviews by the authors in 2009, where they searched for the articles and got 154 abstracts, but in that 133 were not focused on only ISSHL or the treatment, and primarily the vasodilators. So removing that 133, they came to 21 studies in detail, and that they could fit in 3 studies only in Ogawa 2002, Poster 1992, and Knight 2004, which fitted into the category of using alone or with combination of the vasodilators. So according to Ogawa 2002, they divided 2 groups. They gave 60 microgram of prostaglandin E1 and a placebo. Group 2, as a continuous infusion, 100 milligram cortisone. They used combination here. One combination was a vasodilator with steroid, another was without vasodilator, a placebo with steroid. So we have to give away, there is no bias here. The study has no bias because they are using the standard one, that is the steroid along with that. So marked hearing improvement was seen in 66.7% of the PGE1 group. That is the first group where they combined vasodilator and the steroid, but it was reduced in just steroid group to about 64.3%. NE 2004, what did they use? They used carbogen as one of the vasodilator, and a drug course means steroid course. So inhalation for 30 minutes break, followed by 30 minutes of inhalation. The second group was only drug, means steroids. So in the carbogen group, they found that the improvement of the hearing was 76.9%, whereas compared to the drug course only, that is 50% of the control group. So we can see the huge margin of difference here, where the vasodilator was added to the therapy. Oh, sir. They had a monotherapy with low molecular weight dextran and a placebo. That is plasma expander with a placebo. And monotherapy, second group, monotherapy, same thing, plasma expander with nastidrofuril, which is nothing but a peripheral vasodilator by itself through its 5-HT2 antagonist. So there was 70% improvement in the lower frequencies in the combination group of with your vasodilators compared to 40% only with dextran. So these 3 studies proves that either you add the vasodilators to the treatment, where it gives you a positive increased responses for this ISSNHL. Okay. So what are the popular vasodilators we have, which is used for SSNHL? Papaverine, you all of us know, pentoxifillin, Naftidrofurin, 5H2 antidepressant. This is 5H2 HT2 receptor, 5-hydroxytryptamine 2 receptor antagonist. Carbogen is a mixture of 95% oxygen, 5% carbon, as all of us know. A mixture of gases which can increase the cerebral vaso, cerebral circulation is improved by this carbogen, and prostaglandin E1 with vasodilator properties. So the popular drugs what are used as vasodilators. But where did we stop? So we have this. These are old drugs. We had this before. Xantinol Nicotinate. We were using this before, maybe 20 years, 25 years down the lane. Everybody remembers who are experienced here. Complamina, that is what the Zydus market it as, belongs to the class of peripheral dilators. It dilates blood vessels and increases blood flow, especially used in the PDA, that is peripheral peripheral arterial diseases. This process further improves peripheral and cerebral blood circulation. So it is being used some time immemorial for idiopathic, sudden sensory hearing loss. And nowadays, one more thing added is tinnitus, which we think there can be a vascular etiology. Now, coming to this drug, role of vascular is xantinol nicotinate, that is our today's drug. It's a water-soluble derivative of niacin. It was approved as a drug in 1998, that is long way back in Canada, to be used as vasodilator. What is the mechanism of action? It has contained two things, xantinol and nicotinic acid as nicotinate. What happens? The nicotine doesn't get transported in the cell very easily in the circulation. So which the xantinol does? It pushes the nicotinic acid into the cell because both are, one is positively charged, other one is negatively charged. So action enhanced by xantinol, and nicotinic acid by its pharmacological action does all these things: increases synthesis and secretions of protein D2, endogenous prostaglandin, increase the release of nitric oxide, which you know is a powerful vasodilator, reduction of fibrinogen levels, and increase in tissue plasminogen activators, which finally leads into antiplatelet and fibrinolytic activity, vasodilatation, and fibrinolytic activity. So this xantinol nicotinate, that is nicotinic acid, is one drug, is an action drug. Other one drug is a drive drug, which drives the nicotinic acid into the cell. The dosage, what normally we see about. If you consider oral dosage, it's available as 150 milligram, and it can be given maximum up to 1800 milligram per day. Okay, and we have sustained release. This I did not talk to all the experienced guys here, all the experienced people. There is Complamina recharge, which is 500 milligram, which can be given as decided, but maximum to be 1800 milligram per day. Parenteral Complamina injection 300 milligram. Okay, 900 milligram per day. As I think Dr. Samir was telling, 300 milligram PAD we were giving before per day for 10 to 12 days, and followed by the tablets. So we were doing that when we were in very much vogue of Complamina. Indications of this drug, mainly peripheral vascular diseases, that is your lower limb diseases, TAO, and all those things. But sudden sensorineural hearing loss, it enhances the cerebral circulation, aiding recovery in patients experiencing sudden hearing loss by improving blood supply to the cochlea. So the usual dosage and how it is given is 10 milligram per day for 10 to 10 days with a maximum dose of 900 milligram, followed by oral treatment 150 milligram for 1 month. Duration of treatment 1 to 2 months. So we always try to combine this with the standard, the most important steroids. Usually we combine this because we don't know the etiology. Etiology is just brushed off. We don't know the etiology when it happens. So thinking that viral, thinking that it is vascular, thinking that it is autoimmune. So we try to treat them with this idiopathic sudden sensorineural hearing loss. The injections are mostly used for our ENT treatment, that is SSNHL, but tablets and Vitas are primarily indicated for peripheral vascular diseases, and other cerebrovascular disorders. But idiopathic sudden sensorineural hearing loss, the indicated route for this is injections, and it gives a very rapid relief and dilatation of the vessels supplying the cochlea. Adverse effects, peripheral flushing. Most commonly, this is the one which the patient encounters, but it is tolerable. So other things like GI upset, vertigo, rashes, flu-like symptoms, blood vision is all very minimal side effects of what we see. What are clinical evidences we have for this drug? In 1986, remember 1986, I was in my internship. Treatment of sudden deafness with xantinol nicotinate is increasing dosage. So it has been proved in 1986 itself, long back, 40 years ago. So this was studied, treatment of sudden with this molecule. And the study included 29 patients, typically unilateral sudden sensory hearing loss, treated with Complamina with infusion 21 days and 3 months post-infusion tablets. So this is the study what they did in 1986. So results show that 90 improvement was achieved in 90.5%. That is huge recovery. 90.5% increased, improved. 52% returned to normal. 52% returned to acceptable hearing. Tinnitus improved in 92% of the cases and resolved completely in 94%. So this is a fantastic study done long way back, and now we are again revisiting this drug, revisiting this Complamina, and going back and seeing this, we see all this done long way back. So vasoactive therapy with Xantinol Nicotinate, there was a study, retrospective observational, 95 to 2004, almost 9 years. 37 cases were enrolled, hospitalized patients for idiopathic sensorineural hearing loss. Treatment was given as injections, as I told you, in the initial infusion form along with the vitamins, and the dosage was gradually increased daily up to 12 ampules. That is almost 360 milligram or 3600 milligram. So after reaching maximum dosage, it was gradually reduced daily back to the original dosage. So what was the result? They had the study findings. Complete recovery in 62% of the patients with mild to moderate hearing loss. Complete recovery. Partial recovery, 24%. Complete hearing loss experienced symptom relief of tinnitus, but no improvement hearing. That is, always we look into that patients with idiopathic sensorineural hearing loss, also 90% they will have a bad tinnitus, which is buzzing them in the ear. So the last group showed improvement in tinnitus and no improvement in hearing. So it is substantial evidence. It's a very good evidence showing that this can act on the cochlear blood flow. So using vasoactive medication, that is vasodilators in hospitals, effectively treats sudden hearing loss and closely aligns with the underlying cause. So this proves retrospectively also we can take that with these studies, we can always tell that vasodilator has got a role. Vasodilators have got a role in treating the sudden sensorineural hearing loss. The second study, efficacy of combination therapy. So now, combination therapy, that is the steroids, antivirals, vasodilators, and volume expanders, which are commonly what we give for sudden sensory hearing loss, with 34 patients assessed through audiometry. So only Xantinol tablets were given, along with other steroids, antivirals. It is like a decoction. So we give all these things. Sometimes when we beating around and we get nothing out of all our investigation, we try to hit everything with giving this decoction. So Xantinol was in that study for 1 month, prospective study, 34 patients, again for about a 4 years study. What's the results? It's very effective in combination. 79.4% overall recovery was seen in the hearing when combined with steroids, antivirus, and dextrans. That is multiple drugs. 77.8% complete recovery in patients treated within 3 days. All of us know that is within 72 hours they have to come for a good and well-chanced recovery. supports microcirculation. It has been helped mitigate epoxy and vasospasm, aiding auditory recovery. So within 3 days, that is we know that golden days, the 3 days are following the sudden sensory hearing loss. That is when they come to our medical attention. So we treat this like this, according to this study, treat with this multi-decoction type of thing, including a vasodilator. And in this, of course, they have used Xantinol Nicotinate. So 77.8% complete recovery. Early intervention, that is within 72 hours, with combination therapy, including Xantinol Nicotinate, significantly improves recovery in this condition. This is our great Bangalore pathologist, Dr. Vijayendra, who has done a study on this and published in March 2012 in Indian Journal of Otolaryngology and Head Surgery, where they have used intravenous, that is plasma expanders, and along with that, for the initial few days, and then they were put from third day onwards. The patients were given Xantinol Nicotinate 150 milligrams twice daily for 1 month. And the study results showed the patients who came within that golden days, that is not the golden hour, for all MI we call golden hour, we call this as golden days, the 3 days. So they improved. So they improved by 17 improved, 1 did not improve. When the patients belong to group that is 72 hours and above, 10 improved, 6 did not improve. Totally, you combine these two, you have improved 27 among 34, and 7 didn't improve. There is improvement. It is not coming back to normalcy. So it's a high chance. You can see that Xantinol Nicotinate is acted here in this study, and it has proved that we can give Xantinol Nicotinate as tablets after the initial treatment, robust treatment for this thing, either with this drug only or with steroids. But the vasodilators has got a role. With all these things, we can tell that vasodilators has got a role, and better start using the vasodilators for this condition. And one more thing, the recently 2023 Chinese paper told that early detection of stroke at the sudden sensory hearing loss stage. So they have related the cerebrovascular stroke, the sudden sensory hearing loss, as a marker for the detection of stroke, upcoming stroke. A prodromal symptom of ischemic stroke, especially posterior circulation strokes in the anterior inferior cerebral artery area. So this can be a prodromal symptom. That is what they have proven. So we have to be watching. We have to hospitalize them. That is what they tell. We have to hospitalize them and do all the battery of tests to find out the circulation in the posterior part, that is supplied by your posterior cerebral artery, where they can go for even your brainstem infarctions. Okay. So the results reveal that patients with this type of hearing loss who have 3 or more stroke risk factors, and more so with bilateral hearing loss, moderately severe to total hearing loss of unilateral or bilateral, and any intracranial large arterial occlusion, 50% or more, were at a high risk of developing ischemic stroke during hospitalization. So what will help here? The vasodilators. So it is better to start vasodilators. Either you can start it as a like almost we call it as everything we call it as a placebo treatment here in the sensorineural hearing loss, but proven is steroids. So this can also act very well and prevent this imminent danger of people exposed for strokes, brainstem strokes for this thing. COVID. This is a major thing now. So we are all seeing this. Like we are seeing people immediately after COVID, between the first and the second wave, we have seen. After the second wave also, we have seen people coming with tinnitus, unilateral, people coming with unilateral sudden sensorineural hearing loss. So all these things we have seen in this pandemic time, post-pandemic also. So a few case reports were considered when searching the mesh term for COVID-19 concerning this sudden sensory hearing. All of them have shown a positive relation to COVID-19, either presenting with this or post-COVID-19 complications. However, still no apparent cause of it has been found. Only about 6 papers are published since April 2020 discussing idiopathic sudden sensory hearing loss and COVID-19 topic. Most recent paper, there was a COVID-19 patient with no other etiological factor that can cause this, presented with complaint of hearing loss, which on further indications was shown as a sudden sensory hearing loss. Only oral steroids were prescribed for the treatment and the hearing was reversible. So just I'm touching upon, it is not related to the vasodilator talk of mine, but I'm just giving a alert that COVID-19 being a viral infection, so it is causing catastrophes nowadays. We know because of the hypercoagulability producers. Hypercoagulability, we don't know whether to blame the vaccine or whether to blame the virus itself. And the last case which states essential is in April 2020. The last case was, I don't know how many of you have seen after that. Maybe we are still seeing now also. Maybe we are not thinking about COVID. Maybe people who have suffered from COVID, maybe they are coming with this kind of thing. Almost we are seeing youngsters falling down on the floor with acute myocardial infarctions, cardiac arrest, and all those things with hypercoagulability status. So maybe we can relate this to this one. I thank you, all of you, for the patience hearing. I think so. I put my talk little relevant about vasodilator therapy in sudden sensory hearing loss, and we may not only revisit, but we may start. I think so. I want the opinion of the seniors here in the thing. So we have to think about starting vasodilator drug as one of the important drugs in the basket to treat sensory hearing loss. Thank one and all. Thank you. Thanks, Zydus. Thanks, Zydus Group. Thank you. Hello.
Yes, sir. Yeah, Dr. Pranali.
Yeah.
Yes, Tejas sir. So
We
Dr.
request-
Dwaipan,
Yeah.
should I share the slides of panel discussion, or
Yes,
you will
you can
share the
share,
slides?
or otherwise I can also share. I'm
Okay.
sharing.
Okay, sir.
Okay. So after this extensive lecture, right now we can start our panel discussion. Panelists are Dr. V. Srinivas. Already we have heard a great lecture on this topic by Dr. Srinivas. Next, Dr. Samir Bhargav. He was our past president of AY and with vast experience in this topic. When he was the president of AY, he had done a great work regarding this sudden sensorineural hearing loss for the entire fraternity. And Dr. Ravi Meher, professor in Maulana Azad Medical College with vast experience in this topic. So in coming 20 minutes, most likely we will have a great exchange of ideas and thought process regarding this topic. So my first question is to Dr. Ravi Meher. What are the current trends in sudden sensorineural hearing loss development in Indian population, considering age, gender, and comorbidities?
Okay, thank you, sir, for inviting me, and I thank Zydus for this opportunity. What I see in my practice is that most of the patients are actually middle-aged, around 40, 50 years, and many of these patients actually have comorbidities like diabetes and hypertension. And as such, I don't see any gender preponderance for sudden sensorineural hearing loss, but definitely the one of the factor is basically the age. Like they are generally middle-aged and elderly people who are coming with sudden sensorineural hearing loss, as well as many of these patients are actually having diabetes and hypertension, which actually suggests that there could be some vascular pathology, or there could be some microangiopathy, which is very commonly seen in patient with diabetes. So that is my take on this.
Dr. Samir Bhargav?
Yeah, thank you, Dwepan. See, this particular condition of sudden sensory neural hearing loss, we have been seeing it for a very, very long time. But, in my initial years of practice, the numbers were far lesser. And somehow now we find in the last 8 or 10 or maybe 12 years that the incidence has gone up. And I see even younger people. So in their 20s also, I've seen some people who are coming with this condition. It's definitely the chances of people who are diabetic or hypertensive, the chances are a little higher. But I have seen a lot of patients who have neither of these comorbidities. So it's always, whenever I see a patient, it's always perplexing as to what has been the etiology.
Okay. So, Dr. Srinivas, do you want to add anything?
Dr. Samir and Dr. Ravi have given a good overview of this. The only thing is I do agree with Samir Bhargav, sir, that during our earlier days in 1970s and 80s, this was much less talked about condition. But nowadays, this condition has come up so well that we have volumes of books written on the sudden sensorineural hearing loss. That means there is a growing population which are being affected with this, without any age, gender, or comorbidities associated.
Sir, may I add one
So
thing?
this is also to you, Dr. Ravi. How important is assessing and managing risk factors like vascular metabolic conditions and family history in sudden sensorineural hearing loss? And then you can add anything else.
So one thing I wanted to add is that probably there is more awareness about hearing loss, and people are more aware of the hearing loss in the present situation, and that is why they straight away come to us. So whenever they have even slightest of hearing loss, they immediately rush to the ENT surgeon, and probably there is an increased awareness which has come in our population, and the literacy level has also increased. So that is why we are having lots of more patient of sudden sensory hearing loss. And regarding the assessment and managing, so whenever a patient with sudden sensory hearing loss comes to me, I always take a history of about diabetes and hypertension. That is very important, and if required, I will definitely go for some blood investigations also to rule out diabetes, like blood sugar levels and HB1AC level. And family history, I mean, I do usually ask about the family history, but I have not seen any strong family history association in patient with sudden sensory hearing loss. Right, sir.
Okay. This is very important that nowadays the awareness is also increased. Dr. Samir Bhargav, most likely you will also agree that behind this there is a great role of AY also. For last so many years we used to celebrate this World Hearing Day. This year also we have celebrated World Hearing Day from AY, and also this year Director General of Health Service of the central government issued notification to all the states to actually give all the impetus for the better hearing, not only for the children but for the elderly. Now, Dr. Samir Bhargav, what is your opinion regarding this?
Yeah, I agree with Dr. Ravi as regards this, that these patients should be evaluated from the point of view of is there diabetes. I also, like to look at if there is any coagulopathies that this patient could be having. So even a routine CBC and looking at the platelets counts and prothrombin time. You can also, and of course, we don't see that many patients, but VDRL test also must be done for these patients, because rarely you can pick up cases with that. The other thing is very important is the history, as Dr. Ravi mentioned. And sometimes, so we all know that this is a medical emergency. And some of very, very simple tests that can be even asked on the phone when the patients call. Suppose you are like, we are on a Saturday evening and the patient will not be able to generally see a doctor till maybe a Monday morning. And if he calls up at this time, so we can ask the patient to do the hum test. Now,
Right.
the hum test is a fairly sensitive test where you ask the patient that, okay, he says that or she says that my problem is in the right ear. You ask them to say hum, you hum like that. And if they hear the sound in both ears, then it is unlikely that there is going to be a significant hearing loss. If it is a conductive hearing loss, then the sound will go to the side where the patient is not complaining. Okay, but if it's a sensorineural hearing loss, the patient will say, I'm not hearing that sound at all in the affected ear, and it will go to the opposite ear. So the moment the patient tells you this, you tell this patient, yes, this is an emergency. You may be wanting to see the patient even on a Sunday and tackle it as an emergency, because we jolly well know that if it is tackled early, and as Dr. Srinivas in his lecture mentioned, first 3 days, very, very important, then the results will be far better than if the patient reports late. So just this simple test is something which can, help give you a fair idea as to the severity of the problem.
So these are the golden words. This is a medical emergency. Now, this question is for Dr. Srinivas. What diagnostic methods and latest modalities do you use for sudden sensorineural hearing loss in routine day-to-day practice?
If the patient comes for attention immediately, the main thing is when we know that it is depending upon the age of the patient. So if they are elderly or middle-aged or younger age, so we have to do all this battery of tests. And before doing that, empirically, I start with steroid. Once I do the clinical test I do, and immediately I get a PTA done, and if it shows that definitely there is fall of 30 to 40 decibels below 1 year issue. Usually we get this as unilateral one. Bilateral we rarely see unilateral. So if there is a fall in this, definitely a PTA will show. My thing is before going to, we have to admit the patient immediately. It's an emergency, as Dr. Samir told. It's an emergency. So we have to admit the patient, hospitalize the patient, do all the otological, audiological, and radiological, including MRI. So every battery of tests should be done. It should be treated it should be taken as an emergency and do all the things. Meanwhile, I do start on steroids before going to this. So that is how I do this, including MRI, including BERA and OAE. And nowadays, I also include testing for COVID. Testing for COVID, I do for this patients who have recent past after this pandemic, just to know if there is any COVID element in this.
Dr. Ravi, you are following the same protocol?
Sir, I mean, almost similar sort of thing. Like I get a PTA done, and if the PTA shows more than 30 decibel hearing loss in 1 year, I will start steroid right away. But I will not go for MRI in all the patients. I will get MRI and BERA only in cases when I am looking for a retrocochlear cause. So if the patient has some episodes of vertigo and tinnitus associated with hearing loss, probably I will go for a MRI. Or if the patient is having recruitment phenomena, or the audiometry suggests that there is a retrocochlear cause, then I will definitely go for MRI. MRI I don't get routinely in all the patients.
Dr. Samir Bhargav?
Yeah, so MRI is advised for almost all the patients. In this era of medico-legal problems, it is always better to tell the patients that, look here, there can be this very, very remote chance that there may be something that like a SOL which is causing this problem. But yes, you have to go by a case-to-case basis. But I make it a point to mention to these patients that this is an investigation. Right now, we are not doing that. But if it is required, we will definitely do it. And one more thing we need to inquire, Dr. Dayapan, is the other history. This vertigo is very important even from the prognosis point of view, because I have found that in patients who complained of vertigo and giddiness, the recoveries was not as good as in patients who did not have this problem.
So this question is also for you. What is your first line treatment for the sudden sensorineural hearing loss? And how do you choose between systemic and intratympanic steroids?
So my treatment, modalities have actually changed over a period of time. So many years ago, the treatment was including the use of Complamina. So at that time, we were using this very regularly in the drip form. So the patient used to be admitted. I used to give the patient along with Complamina also high dose of Solumedrol. Okay, so 500 milligrams of the steroid, which was given intravenously. Then we came across the American guidelines, and where they very categorically, through all the various meta-analysis, came to the conclusion that it is whether you use steroids oral or intratympanic, the results are equally good. And they also mentioned the use of hyperbaric oxygen. So of late, I have been, if the patients are not benefiting with only the steroid treatment, then I suggest that they go for hyperbaric also. So most of the time, my patients are started on oral steroids, a high dose 1 milligram per kg body weight of the oral steroid. I call the patient back after about 3 days, and if there is no improvement at all, subjectively or on a PTA, then these patients, then I suggest that we need to go in for an intratympanic steroid.
Okay. Dr. Ravi?
Sir, I am also following almost similar sort of therapy, and the initial treatment is basically with oral steroids and 1 milligram per kg body weight of prednisolone I give. And in case the patient does not improve, the patient can be started on intratympanic steroid. The dose of dexamethasone which is available in India is basically 4 milligram per ml, right? So ideally, in the literature, even 24 milligram per ml dose is recommended, but in India we are not able to get these vials. So maximum dose which is available in India is around 10 milligram per ml vial is there, right? So if you are able to get hold of 10 milligram per ml, then you can actually use this. Otherwise, normal dexamethasone which is available in ICU can be used. And I usually give intratympanic injections twice weekly for 2 weeks, right? And if the patient even does not, I mean, even if the intratympanic steroid patient does not improve and does not show significant improvement, then I usually send the patient for hyperbaric oxygen therapy, right? So the problem with hyperbaric oxygen therapy is that it is not very freely available. In Delhi, we have only 2 centers. One is the government center, which is at RML, and other is the Apollo Hospital. So, I mean, I am treating patients from government setup. So many of these patients are very poor and cannot afford the hyperbaric oxygen therapy. And I usually send them to RML Hospital, where there's usually a very long waiting list for hyperbaric oxygen therapy. So these patients should receive hyperbaric oxygen along with intratympanic steroid. Right? So that is the treatment I'm following.
Very important point that Dr. Ravi brought up is regarding the strength of dexamethasone vials that we are getting in our country. So when world literature is talking of results of 64% and 70% and 79%, unfortunately I am not getting these kind of results.
Right,
So
sir.
my results are somewhere between 35 and probably 45 or 50%. More than half my patients are not improving. Probably the difference is in the strength of dexamethasone that we are using. Having said that, in the past, we had patients who even used to come with spontaneous recovery. So,
right,
when I find these results, I find them too hard to believe that they are getting such great results. Also, when you say improvement, so whether it is a 10 decibel improvement or a 15 decibel, or is it a 30 decibel improvement? So the criteria are very clear as to what is labeled as a partial recovery or a full recovery. But the moment the hearing loss with the patient is more severe and profound, my results have not been really very good. So these patients, I always tell them that the prognosis may not really be very good, but we have to give you whatever is possible. So quite often what I'm using is actually a cocktail treatment. Even if the guidelines are mentioning that it is only steroids and hyperbaric oxygen, which is the ones, in fact, very many places they categorically say that you should not be using any antivirals. But in my treatment, I'm using a cocktail because I do not want to take a chance with that patient. If it was my year, I would have definitely done everything possible.
Okay, so this is for Dr. Srinivas. How effective is xanthine nicotine in sudden sensorineural hearing loss treatment, and which patient profiles benefit most, and what is the treatment duration? Dr. Srinivas.
Effectiveness of xantinol nicotinate have already proved with some studies here, which I've shown everybody. The studies which shows that it has got a powerful role in playing this in this sensory hearing loss. Personally, if you ask me, yes, about 20 years back, we had these Complamina injections. We used to give initially 900 milligrams per day, divided doses for 10 days, and with steroid with with parenteral steroid with these people, especially they come within the 72 hours. So we count the combination of these two has we have found a good relief. But the thing is, those days patients were, as Samir was telling, that there was no awareness. There was no awareness about this thing. So they just used to pass by this hearing loss and come after the first 72 hours, where we had to use combination only. And before that also, it is better to use combination. And we have found it is effective. And we have found that is 50 to 60% of the people have the chance of recovering up to 70 to 80% of what they had combination. But I'm not done any studies comparing the only steroid and steroid with xanthanol. Only thing is we have evidence. These are the papers which I showed you people. So it should be effective if you combine in combination with steroids. And which patients benefit most? Of course, people who are vulnerable for any kind of peripheral arterial diseases. So when they show that there is some kind of uncontrolled diabetes people or something like who have got long-term diabetes people who show that when we do a leg Doppler studies, you can do a leg Doppler study in such people, and you can see that there is peripheral artery diseases. So they will benefit most if they suffer from the central sensorineural hearing loss. The treatment duration, initially infusions for about 10 days, as I told you, 9 milligram per day, and followed by either Complamina plain 150 milligram or at retard, that is 500 milligram for 1 to 2 months. So that is the thing what we have to use for this recovery. Thank you.
Okay. Dr. Ravi?
Sir, frankly speaking, I don't have any experience of using xantinol nicotinate in sensorineural hearing loss. And I was going through some of the research articles which are there on this product in the treatment of sudden sensorineural hearing loss. And what I found is that there are not very good, robust RCTs available to prove its efficacy, right? There are definitely some papers available which shows that it has shown improvement, but what I feel is that there should be some good evidence generation for this product, right? And there should be some research, further research on this molecule in the treatment of sudden sensorineural hearing loss, and we should plan maybe a good RCT, a well-designed RCT with comparison to steroids, right? So if we design some study, we have to include steroids because we cannot, it will be ethically wrong to not start steroids in these patients, right? So probably there can be two arms with one patient receiving steroid along with the xanthinol and other patient receiving only steroids, and then probably I mean we can generate some good evidence for use of this, because this product is actually not available in the recent guidelines which are there on sudden sensorineural hearing loss. So one of the important guidelines which is there is by Dr. S. Chandrasekhar, which is published in which is published by American Academy of Otolaryngologists and Head and Neck Surgery from USA. So if you go through these guidelines, the xanthinol does not find its place in the guidelines.
Dr. Samir Bhargav, what is your opinion?
Yeah, so as I mentioned that many years ago, I was using this Complamina drip and in the dosage of 900 milligrams and but of course along with the steroids, and overall, as I said, my results are less than 50% improvement in the hearing, and so it was at that time also. I do give the patients a tablet Complamina retard 500 milligrams twice a day for 15 days after I have given the patient the whether oral steroids or intratympanic steroids. So I agree with Dr. Ravi that we should do more detailed analysis of this. And this paper and in fact the guidelines which Sujana Chandrasekhar came up with and it was with a lot of people who contributed to that. There they have very clearly mentioned the role of only steroid and hyperbaric oxygen. But I am not so convinced about the hyperbaric oxygen also. So I think
Yes,
we should look at it again from our Indian context also. Because even
right.
those studies, if you see that those papers are so varied, some people have used intratympanic methylprednisolone, some have used DEXA.
Yeah.
The dose, as you mentioned, 4 milligrams, 8 milligrams, 24 milligrams. The duration has been different. The number of times that you have used, some people are using it once in a week for 5 weeks, some are using it twice a week. So there has been no very proper protocol. And then also the comparison has been done. So I think we should have an Indian study on this, definitely.
Right.
Sure.
I would invite the Zydus group to, before starting revisiting Complamina, they can do a multi-centric study about this. It should be a multi-centric study because the volume will be less if it is only one center. Multi-centric study across the India, where we can get an input and we can try to see how much effective this campaign is because we are revisiting it.
Okay, now
Sure,
this
sir.
question is also for Dr. Srinivas. How crucial is patient counseling for the treatment adherence and prognostic complications in sudden sensorineural hearing loss?
This is a very important aspect of anybody who is treating sudden sensorineural hearing loss. See, without a proper counseling, patient will never understand that this is a medical emergency. So first thing, they should understand that this is a medical emergency, an audiological emergency, and we should always, I feel that, scare them to the level that they should get a treatment, that tell them that this is like your heart attack. Your ear has gone dead because of the heart attack. So how you take the heart attack? If you get a heart attack, how do you take it into your mind? So that kind of scariness if they get about this. And nowadays, as I see that because of this increased use of the earphones, headphones, and all, people are sensitive for minor changes. Even minor change they notice because of the wide use of these earphones and these things. Everybody across the status, whether no gender, no age, everybody uses. So even minute change from one year to another year, immediately they'll come to know. And nowadays they'll come immediately. They'll come within at least 24 to 48 hours. They'll be not hearing. They want to use the earphones, so they will come. So the thing is, counseling is very, very important here, and we should always we have to give them that scariness. And the prognostic complications, of course, we have to tell them that the only thing is if you don't have the treatment, then it is the final thing is you have to go for a hearing aid, and we may not be able to help also. And finally, we don't know. We may go in for cochlear implantations also. So that kind of knowledge they should have. Thank you.
Okay. So this is for Dr. Ravi. Are there any recent advancement in sudden sensorineural hearing loss therapy that you find promising in near future?
So in near future, probably we will have better drug delivery system to inner ear. At present, what we are doing, we are injecting dexamethasone directly in the tympanic membrane with a needle, or sometimes we are using a microwick, right? A Silverstein microwick. But normally, what I do is basically I take a tuberculin syringe with a 26 gauge needle. I inject the drug directly into the middle ear, right, through the tympanic membrane. But in future we might have some nanoparticles delivery system, which will improve the availability of the drug inside the inner ear. So that is one of the things which is going to be there, and probably very in the near future we might have better drug delivery system for the inner ear, right? And I think that's all I would like to say.
Okay, Dr. Samir Bhargav.
Yeah, I agree that the drug delivery is very important, because if we believe that we can get into the inner ear through the round window membrane, then we need a better drug delivery, because here we are leaving it too much to the chance that that much of the drug will go in. So probably better drug deliveries will come in future. Otherwise, as far as the current treatment protocols are concerned, we have all discussed that.
Okay, so with this, I conclude this panel. So thank you, Dr. Srinivas, Dr. Samir Bhargav, Dr. Ravi Mer, for this lively interaction, and I hope this
Sir, I
panel
think there are some
discussion and this
questions.
lecture. Yeah.
So I think there are some questions in the chat box. Maybe we can take those questions.
Yeah, Dr. Pranali.
Yes, sir. So thank you to our esteemed panelists for such an engaging and informative discussion. Your insights have provided a deeper understanding of the vascular approach in managing hearing loss, and we have covered a wide range of topics from diagnosis to treatment. So now let's move on to the Q&A session. We have received some excellent questions from the audience in the chat box, and I'll start by reading those out to our panelists. So let's begin with the first question from the audience. What are the key red flags that should prompt a general physician to refer a patient with sudden hearing loss to an ENT specialist urgently? So what are the key red flags that should prompt a GP to refer a patient
Dr.
to
Samir.
specialists?
Yeah, so the patients quite often will go to their GP saying that their ear is blocked. So if the simple test, as I said, the hum test, if the GP can do, so we need to create awareness among our GP population also, so they will be able to diagnose whether this is the one that is serious or not. The other thing is, if the patient is also complaining about tinnitus, if the patient is having giddiness, then these are the things that the GP should definitely ask the patient to go to an ENT surgeon as early. Having said that, any patient who says that, oh, my ear is shut and I cannot hear, must receive a consultation with a specialist.
All right, so next question. What immediate treatment option, for example, steroids or vasodilators, can a GP consider before referring an SNHL patient to a specialist? So some immediate treatment option for a GP.
Dr. Ravi.
So I would suggest that the patient, if patient is complaining of sudden hearing loss, he should be sent to an ENT surgeon urgently, because this patient will require an audiometry to diagnose sudden sensory hearing loss. Right? We have to actually, differentiate it from a conductive hearing loss, which could be because of impacted wax or water entering into the ear and causing swelling of the wax. It can also cause hearing loss, but that needs to be differentiated from sensorineural hearing loss, which occurs in sudden sensorineural hearing loss. So it is important to send the patient to a ENT surgeon so that audiometry can be done and we can actually differentiate, yes, it is sensorineural hearing loss, and then only the patient should be started on steroid, right? We can't start steroid without any definitive diagnosis of sudden sensorineural hearing loss.
Okay, so next question. What key effectiveness parameters, then population subgroups, treatment duration, and follow-up schedule should be considered for a real-world evidence study on Complamina? So what should be the key effective parameters for the RWE study for a Complamina?
I think Dr. Pranali, you can give answer.
Yes.
Yeah. Yes.
So I think PTA would be the first parameter, followed by the decrease in the severity of tinnitus and vertigo. Also, we can consider some patient patient-reported outcomes, like how satisfied they are with the treatment. So from them, what do you all think is the best parameter to carry out the study?
Dr. Srinivas?
So,
See, the thing is here, the problem situation arises that we don't start any treatment without steroid. And without steroid, we don't treat anybody. So it is all added things. Your hyperbaric oxygen or carbogen or vasodilator is all added. And the main thing is that the parameters, when you set it like that, so the parameters are very difficult to be set like that. Unless we have, as we told, that there should be a good randomized control study, then we can come out with these parameters. Otherwise, it remains steroids, but all these are the additional things what we can use. That is my opinion. It is difficult to come out with parameters for these things unless we have a wide random RCTs on the use of Complamina for the sudden sensitivity as a sole drug.
Okay, so then which population subgroup should we consider for this kind of a study?
Well, I told you, people are vulnerable for all the peripheral artery diseases, the age group, the diseases, the comorbidities. All these people can be considered for the study with hooks, land up in Sensorineural. That would be a better group than including all the other groups, because those people, definitely they will have peripheral artery diseases, and these vulnerable group definitely would be benefiting with this vasodilators, and those people can be enrolled in the study.
Okay, so. And what should be the treatment duration with vasodilator?
I've already told that initially they come, that is the infusions, followed by tablets, maybe for 15 days to 1 month. You have to give, better to give retard rather than simple Complamina. Should be 500 milligram BD for at least 15 days to 1 month post infusion.
Okay, sir. And how frequently should we follow up the patients to see the recovery from hearing loss?
See, they come within 3 days, and if you start the treatment, 7th day is audiology. Audiology only, but mainly audiology. Audiological recovery, audiological test should show the recovery. At 7th day, I would do it at 7th day, in 21 days, and 6 months later. To know the recovery.
Noted, sir. Then, can we use this vasodilators in idiopathic facial nerve palsy, and for how many days can we use it?
That is
Dr.
going
Srinivas?
beyond the scope of today's discussion.
Yeah.
Topic is
Yeah,
different.
it's not. Okay. And is it effective in oral submucosal fibrosis also?
No. Totally different.
Okay. And what is the last question? What is the advantage? No, we have a few more questions. Okay. What is the advantage of Complamina retard over nimodipine?
I don't have any experience. Sorry, anybody?
No idea. What is nimodipine?
Nimodipine is basically a vasodilator which is used for controlling blood pressure. So I think I don't have any experience of Complamina or nimodipine.
No, same here.
Yeah.
Okay.
Pentoxicillin, yes, but not this drug. With pentoxicillin, yes, we have some experiences with pentoxicillin, but not with this another antihypertensive what has been mentioned.
Yes, sir. And so, considering hemorrhage as a cause of SNHL, can the use of vasodilator worsen the situation?
Yeah, as we know, that is idiopathic sudden sensorineural hearing loss. This is 90% idiopathic. We don't know the reason, right? So in that context, it is very difficult to find out whether it is the hemorrhage or whether it is the infarction. Either these two things. So with this context and with the empirical therapy what we have, it is better to start on the vasodilators. Okay, hemorrhage, even if it happens, I think so. It is not. It has not been proven. There is no evidence base. as Dr. Ravi told, nothing is evidence-based. Most of the drugs what we are using is almost empirical. So nothing evidence-based. So that the only evidence-based little bit what we have some studies is steroids. Otherwise, nothing is evidence-based. So we cannot take this as a thing, and empirically we have to give this. It is not that we cannot prove that it is hemorrhage or infarction as you can do in cardiac conditions. We cannot prove.
Understood, sir. And when to choose an intratympanic steroid and when not to choose an intratympanic steroid. Time for choosing an intratympanic steroid, which cases, then when intratympanic steroid ceases its indication with normal tympanic membrane patient. So I think when the question is when and when not to choose an intratympanic steroid, and what is the time for choosing intratympanic steroid in which cases?
Already these
Dr.
We
points
have
are
already,
discussed.
yes.
Already these
You already-
points are discussed.
Yeah, Ravi has already spoken in detail about this.
Yes, sir.
Yeah.
Okay, okay. So thank you to our panelists for this for their insightful responses, and to our moderator, Dvaipan sir, for guiding this engaging session. Now, I invite Mr. Durga Prasad to conclude the session with a vote of thanks.
Before I conclude, Nitish sir, do you have anything to stress? Do you want anything to quickly?
I think this was a very, very insightful discussion and the presentation. And thank you so much, all the elite group of the panelists for making it so vividly clear to the audience. And I also note very strongly the point and the suggestions which you have made about conducting the RCT and having more studies on that. We take it on a positive note, and we'll discuss with all of you to take it forward. Thank you, sir.
Yeah. So at the outset, I thank each and every one. Today being the first day of IPL, it was a challenge for us to bring the audience, but we have fairly succeeded with 2,500 registrations on and 1,500 live viewership. So all thanks to Dvaipan sir and Deepak sir for conceptualizing this concept and timeless therapy of SSNHL, sudden sensory neuro hearing loss. And as agreed by all the panelists here, Samir sir, Srinivas sir, and Ravi Meher sir, that the incidence is increasing. So this therapy is going to be relevant in the coming days. And I thank you so much, Dvaipan sir and Srinivas sir, Samir sir, Ravi Meher sir, for all of you for taking your valuable time on a Saturday evening, and the questions which you've been answering this. I think I could see this academics, the interest which you're showing. You're not doing a program for the sake of doing it, and the insight is so good for us. For as Nitish sir said, we will surely look into RCT, and we are surely reviving our connectivity at ENT front, and this gives us confidence to move forward for our entire pharma team to work on the ENT fraternity. And I take this opportunity to thank each and every one of you once again for giving us this opportunity on a Saturday evening. And I would say it is an academic feast for last 1.5 hours on the old therapy, which you have made more interesting. Thank you so much, one and all, and my entire team, and Dr. Pranali for coordinating, and the field which has been successful in bringing 1,500 odd doctors, all ENTs, to watch this e-webinar live. Thank you all.
Thank you very much, and good night.
Thanks to all.
Thank you.
Thank you so much to
Thank you.
everyone, and it was a pleasant.
Thank you, our technical partner.
Shraddha is the brand manager for this Complamina, and she has taken a special pain on organizing this. So thank you, Shraddha, for making this event possible.
Thank you so much, sir. Thank you all the panelists.
Thank you.
And
I
I
wish everyone a great weekend. Thank you very much.
Thank you.
Good night. Shubhraatri.
I look forward
Thank
to
you.
meeting
Good
you
night.
all at your clinic.
Sure.
Yes, sir.
Thank you, everyone. Thank you.
Thank you.
Thank you. We'll take up the RCT part as you suggested. Thank you.